So again, welcome to what will be a great session here with Dr. Kudron, who is an assistant professor in the Department of Biomedical Informatics at the University of Colorado School of Medicine. She trained at University of New Mexico, as well as Nationwide Children's Hospital, Ohio State, and again, has now 6+ years of recognizing the potential of personalized and precision medicine to transform healthcare. She serves as the Associate Director for Program Education in Colorado, where her efforts focus on translating precision medicine and co-directs a graduate certificate program and several other things, as well as continues to see patients at Children's Hospital of Colorado's primary care pediatric clinic, the Child Health Clinic. So we have had some nice back and forth, but I'm really looking forward to Dr. Kudron's talk today and appreciate that 83 of you are here. So Dr. Kudron, thanks for being here.
Thank you so much for the introduction. I really appreciate it. I am very excited to be here with you today. I'm going to try and consciously talk slower than I normally do. As many of you are aware, we have live interpreters for the conference. So today I am going to discuss genetics and primary care, a vision for the future of precision medicine. I do not have any relevant financial disclosures related to this talk. Here is a roadmap of what we are going to discuss today. We are going to spend a little bit of time getting to know each other. Then I will provide an overview of precision medicine and primary care. We will take a deeper dive into pharmacogenomics. And if you're unfamiliar with what that term means, I will define it for you. And then we will look at direct-to-consumer genetic testing. And lastly, we are going to end with how you can integrate precision medicine into your life, whether you are a healthcare professional, a patient, a family advocate, or an educator, and you might be all of those things. So we'll start with our learning objectives for today's talk. We will review 3 genetics resources that can be utilized in the primary care clinical setting. We will reflect on how patients can benefit from having genetics integrated into primary care. And lastly, we will consider engagement. So I'm going to describe how families can engage with their primary care provider, or really any healthcare professional, in conversations about precision medicine and the use of genetics in their care. And we're also going to consider how clinicians can incorporate precision medicine into their practice. So before I launch into kind of my own experience and how I got here, and go into the details of our talk today, I would love to get to know you a little bit more. That helps me to kind of gear the talk toward the audience. So we are going to launch a Zoom poll. And this says, tell us about you, and you can choose more than one of these. I'm going to pause so that I know you've seen this poll multiple times in the conference. I'm going to pause to allow you to answer this. And then we'll look at where our audience lands.
We have nearly 80% of people have answered. That number keeps climbing, so I'm going to give another 10 seconds or so for people to answer the poll. And I'm going to close the poll in 3, 2, 1, and here are the results.
So it looks like we have a really large number involved with genetic counseling, which is fantastic. About 10% family or family advocates, some MD or PhD geneticists and industry representatives, as well as other. And feel free, if you are willing to share, to put the others in the chat, because I know that we tried to encompass all of the different roles that we possibly could think of, but I'm sure there are things that we missed. That's super helpful to me as we move forward. So I will tell you a little bit about me, and you already heard some of this in the introduction. So first, I want to thank you for being here today, and hopefully this is helpful talk for you. I think it's important whenever you're hearing someone talk to know their own background and the perspective that they're bringing to what they are teaching you or what they are hoping to bring to you. So I knew from a very early age that I wanted to be a pediatrician. And the reason I felt like that is that childhood is this very influential time where you are building long-term health. And I felt like I could impact a person's entire life by helping them build healthy habits early. And I did practice pediatrics, both in a hospital setting and a private practice setting. And during that time, I noticed an issue, a big issue in healthcare that many of you in healthcare may have noticed, is that researchers and scientists can work very hard to make amazing discoveries, but it can take years to have this new information incorporated into the routine care that you receive when you go to your doctor. And I felt like that was very frustrating. I came to realize that doctors, nurses, genetic counselors, everyone that's part of the healthcare team really needed systems that could prompt change in behavior to provide the best possible care. So that's when I decided to pursue a degree in public health with the goal of learning about health systems management and how to change the healthcare system. And while pursuing my master's in public health, I was introduced to a new domain of medicine called precision medicine or personalized medicine, and felt like this was my gateway to making lasting change that could impact not just my patients that I see every day, but impact patients across the healthcare system, across the state, even nationally. And that's where kind of going from taking care of children to public health to precision medicine and how I got there. So I really look at precision medicine from a public health lens and thinking about right now, the focus is on adults, but how do we move that toward children? So before I define personalized and precision medicine, which has a lot of different definitions, so it's important for all of us to get on the same page, I would really like to know what you think about personalized or precision medicine. So we're going to launch a word cloud, meaning that you will type in words, and then as people type them in, you'll see words popping in. And the question is, what are 1 or 2 words that you associate with personalized or precision medicine? And I'm going to pause to let you answer that. And as responses come in, you'll be able to see them.
So as Dr. Kudron mentioned, and a lot of you have found, that link is there in the chat. If you click that link, it'll open a separate browser window and open a text box, and you can type the words as many of you are doing.
And I appreciate that some of you are putting this in the chat as well. That's really helpful. All right, Fred, maybe we'll pause in just a second because I don't think we're yet changing a ton now. So you can see that there's a lot of different things that people think about personalized and precision medicine. And I love starting with this because it really gives not just myself, but you as an audience an idea that we're coming at this from all different perspectives. The biggest ones I see here are targeted, tailored. I see pharmacogenomics, pharmacogenetics, genetic testing, individualized, customizable, focus, specific, lots of work, expensive, customized. One of them says non-existent, cutting edge, a lot of right med, right dose, and I saw that in the chat as well. Improved outcomes. And I think we're going to touch on a really large portion of these today. I'm going to share my screen again, and I really appreciate you taking the time to put that in. Let me just share my screen. So I've asked this question of a lot of audiences, and interestingly, when I talk to healthcare professionals, often genetics professionals or other physicians, expensive is the term that comes up more than tailored. And I think that comes from this perception that we're very far away from precision medicine. So it's great to see in your group. And I think that we're seeing tailored more because so many of you are so educated in genetics compared to many audiences, that you recognize that maybe this is more on the potential front already and not as far away. Other things that came up with your group that I see when I've done this with other audiences is future change. Always genetics comes up. And then a big one that I didn't see as much with your group, but I've seen with a lot of groups is machine learning. And people will put kind of precision medicine, artificial intelligence, machine learning together. I'm not going to talk at all today about artificial intelligence or machine learning or how that relates to precision medicine. I just want to acknowledge that a lot of people put those kind of categories together. And I'm also not going to really talk about the costs of any of this today. That would be a whole other separate talk. And so I want to acknowledge that we're going to focus on actually what many of you put as we're going to focus on the tailored, on pharmacogenomics, on the targeted pieces, and on the future and the change pieces. But I want to acknowledge that there's parts that we won't get to. And that's just simply due to the complexity of this field. So let's all get on the same page about what personalized or precision medicine is. So in order to really be able to talk about this, I think it's important to distinguish between these two terms. And a lot of people, even myself, will use them interchangeably. The era of personalized medicine is often considered to have started with the Human Genome Project. And this was the initial term used to describe the use of a patient's genetics to predict the risk of disease and treatment success. And through many biomedical advances, the focus on genetics has left the impression that personalized medicine has relatively narrow applications, mainly for people with certain cancers and rare disease. You'll often hear people say personalized medicine. But what I like is this quote. This is a pretty recent quote from Christopher Wells in 2021. He nicely described that in its simplest sense, personalized medicine acknowledges that no two people will encounter the healthcare system in exactly the same way. Viewed through this larger lens, it assumes that the more closely healthcare can be tailored to each individual's biological characteristics, circumstances, and values, the better off they and the healthcare system will be. And I really love this broad definition because you can see it nowhere does it say genetics. And it brings in all of these aspects of healthcare that all of us are working toward, no matter if we're primarily in genetics or primarily a non-genetics healthcare professional. And I like this because it keeps things broad. And when we really bring in the genetics piece is often when we move toward precision medicine. And so there was a 2011 report from the National Research Council that announced the preference for the term precision medicine instead of personalized medicine when referring to the integration of genetic information when patient health data is used with genetics to improve prediction of risk and treatment success. And many of you are probably familiar with President Obama's announcing the Precision Medicine Initiative in 2015. And this is a quote that President Obama stated at that time, where he said, "Doctors have always tried to tailor their treatments as best they can to individuals. You can match a blood transfusion to a blood type. That was an important discovery. What if matching a cancer cure to our genetic code was just as easy, just as standard? What if figuring out the right dose of medicine was as simple as taking our temperature?" And this is a quote many, many people use. It's very familiar, and it does bring in those genetic pieces. I think no matter which term you use, it's really important to consider that personalized medicine can go beyond genetics Today, we're going to focus on those precision medicine pieces where we're really going to focus on genetics and how that can impact medicine and primary care. So to look at this in a different way, I really like this diagram that starts off with traditional medicine and we're going to move to precision medicine. So for the purposes of this diagram, I want you to pretend that you've gone to your doctor, you've been diagnosed with severe heartburn, and you want to start a medication to help with this severe heartburn. So in traditional medicine, everyone with one disease or condition, in this case, heartburn, is given the same therapy and then monitored for effectiveness. And some people may experience an adverse event. You can see these people in the darker blue. Some people may experience no benefit in this lighter blue to gray. And then you have these people in yellow that experience a benefit. And what this results in is sort of a trial and error process to find the right treatment for a patient. And you may have experienced that yourself, where you've gone to your doctor and they've given you medicine and it didn't work. Maybe it worked for someone else. There's another category in medicine called stratified medicine. And in stratified medicine, patients are grouped using some type of marker. So they could be grouped based on demographics, clinical features of a disease or disease subtype. In our example, let's say you had severe daily heartburn, and that's different than mild heartburn that maybe you experience sometimes. And so patients that have severe daily heartburn might receive a different treatment than those who have mild heartburn. And then we know that when patients are grouped like this, that these more targeted treatments can have greater benefits, meaning someone may receive relief sooner than if we just gave everyone the same treatment. In precision medicine, we take this the next step further, and we then individualize or personalize care based on a number of factors. And you can see the top one here is genomics and omics. I'm not going to go into all of the different omics today. We're really just going to focus on traditional genetics. But when we integrate genetics with a patient's health history, medical records, even lifestyle, that all brings precision medicine to the forefront. In our example, if you have severe heartburn, then you might undergo genetic testing and determine that you have a genetic variant that impacts the metabolism of the most preferred treatment for heartburn, and it makes the medicine less effective for you. And so then instead of your doctor prescribing that medicine and it's not effective or you have side effects, genetics can influence that treatment so that you can be started on the right medicine at the right dose to have the most effective treatment as soon as possible. And that's really a key goal in precision medicine. That's kind of gets into pharmacogenetics, so we're going to talk about that in a minute. Before we move on and talk about pharmacogenomics, I just want to acknowledge some really important applications of precision medicine in primary care. And one of the biggest is the newborn screening program. I'm sure many of you are familiar with this. I bring it up because a lot of people don't think of it as precision medicine. For those who are unfamiliar, it's a mandatory state-based public health program that provides all newborns in the United States with testing and necessary follow-up healthcare for a variety of medical conditions. The way I tell my patients is this is genetic testing that looks for conditions that I can't see by looking at them. And newborns are screened at birth with a heel poke and then again at 8 to 14 days of life. And this program has been in existence for a long period of time, well before my lifetime. And it's really an amazing example of what we've been able to do with the use of genetics in primary care and care in general to prevent infants from going on to develop serious conditions that can have significant morbidity and mortality, meaning they can have significant side effects or even death. Another example of precision medicine that comes up a lot, and I know we have a large audience of those of you that are involved in genetic counseling, and so this is one that will be very familiar for you, is the use of genetics to predict disease development. So 1 in 300 to 500 women have a mutation in the BRCA1 or BRCA2 gene, and that gene, often referred to as BRCA, it accounts for about 5 to 10% of breast cancer cases and 15 to 25% of ovarian cancer cases, depending on the study that you look at. And because of the prevalence of this gene and its association with cancer, the United States Preventative Services Task Force recommends that primary care providers assess women with a personal or family history of breast, ovarian, tubal, or peritoneal cancer, and they have or if they have an ancestry associated with BRCA1 or 2, which is typically a European ancestry. And then women with a positive result will undergo typically genetic counseling and further testing if appropriate. But the biggest thing is that if we know that someone has one of these genetic variants, then they are able to undergo screening and potentially treatment for breast cancer much sooner. So this has really impacted our ability to detect breast cancer before someone has significant issues from it. And lastly, and this is where we're going to focus a little bit of time, is that we can have treatment outcomes improved when we tailor our treatments to an individual patient, like we just talked about on the last slide. Medication response can be difficult to predict, and it can feel like, I liked this diagram because it can feel like you're walking around blindly, just giving patients different medications, trying to figure out what works best for them. And genetics can be used to anticipate medication response. And that's the area of pharmacogenetics or pharmacogenomics. So we're going to move into talking about this field. And I want to highlight that we can get genetic information from a lot of places. So the biggest one that we see is provider order testing. So you go to your doctor or your clinician, they order a test, and then you receive those results. One big area that we're going to talk about in a little bit is direct-to-consumer genetic testing. And then one that often gets forgotten is that patients can enroll in research studies or biobanks. And biobanks are generally large research studies where samples are collected and then stored for future research. And some biobanks and research studies will return genetic information to patients. And that's where we're seeing precision medicine really move forward quickly, because there's only so many direct-to-consumer tests that, they have a certain market. We'll talk about that market. And then provider order tests is limited by the number of providers that are ordering those tests. So I'm going to define pharmacogenomics for you. And the most important definition for pharmacogenomics is that you're using genetics to predict medication response, and particularly toxicity. And before we kind of move into some of the details of that, we're going to launch another poll, because I'd love to know, this will help me guide with the slides, how familiar are you with pharmacogenomic testing? And I will let you read through the responses and pick one of those.
So those answers to the poll are coming in. I'll give another 15 seconds or so for people to answer. And if you are in this meeting and the Zoom polls are not popping up on your screen, that likely has to do with updating Zoom. So if you're someone for whom that's true and you'd like to see the polls, if you have a chance today to update your Zoom, that should make the polls available to you. All right, I'm going to close the poll in 3, 2, 1. And here are those results.
So it looks like a lot of you are more familiar, and that's not actually surprising since so many of you seem to be more educated about genetics than kind of an average audience, which is great. So 30% very familiar, 61% somewhat familiar. That's actually great for me because we can kind of move through some of this a little bit. We can kind of focus in for what's appropriate for all of you. In terms of what we know from the literature, we know that physicians feel, and the reason I focus on physicians is a sort of, we're focused on a primary care bent with this lecture, is that physicians feel generally uninformed about pharmacogenomics. And the bar graph here, each bar represents a different study from around the world, although most of these are from the United States. You can see that 16% of physicians, when asked, felt confident in applying pharmacogenomics in the clinical setting. That's pretty abysmal. And then the two lower studies, only 10% felt very familiar with pharmacogenomics. And then the middle study, 10.3% felt adequately informed about pharmacogenomics. And there was a study of physicians that found only 2% thought that they had good knowledge of pharmacogenetics. And so this really shows that although some people may feel familiar with it, they may not actually be able to have the knowledge to order that testing, but that there's a large knowledge gap for physicians. And in order for this to be utilized, we have to figure out how to fill this gap. So we've talked about pharmacogenomics and kind of what it is. So I will just briefly highlight that we're utilizing genetic information to guide optimal drug selection and dosing. I really like the diagram here on the right, where you have these different patients, and some respond to a normal dose, some respond to a lower dose, some respond to a higher dose, and then others respond to an alternate medication. Pharmacogenetics is important because it's, for a lot of people, they think, oh, this is super future, we're not doing it very often. However, the Federal Drug Administration, or the FDA, has placed a fair amount of importance on pharmacogenomics. They include pharmacogenomic information in drug labels. They have a table of pharmacogenomic associations with hundreds of medications on it. And as I showed you, many prescribers are really uninformed about this area. There are many common medications that are impacted by genetics, and this is just a little snippet of some of those. The statins that are used to lower cholesterol, NSAIDs or non-steroidal anti-inflammatory drugs, like ibuprofen or Aleve, which are used for pain relief, the proton pump inhibitors, and that's why I used the example of heartburn earlier, like ibuprofen or Aleve, I apologize, like Prilosec or Nexium, and then many antidepressants. And this is just kind of a small sampling. I think the key here is what resources, if our clinicians don't know about pharmacogenomics or know how to utilize it, what are the resources that can be used to gain information about this area? So one of the most important is the Clinical Pharmacogenetics Implementation Consortium, or CPIC. And CPIC is an international consortium of volunteer pharmacists, clinicians, industry experts, and others who are interested in facilitating the use of pharmacogenomics in clinical care. When the scientific evidence for the relationship between a specific gene and a specific drug is high enough, they consider that level 1 evidence, and this is just a way that the evidence is rated. Level 4 meaning there's barely any evidence. Level 3 kind of moving up into case reports. And level 1, the ideal is a double-blind randomized control trial, which is very unusual in pharmacogenomics. However, when there's larger case studies or cohort studies that show an association, then things may be moved to level 1. And so what CPIC does is they review the literature and they write a peer-reviewed, evidence-based clinical guideline that is designed to help clinicians understand how available genetic test results should be used to optimize drug therapy. The key thing is they're not telling anyone when they should order genetic testing or whether it should be ordered. They're just telling them, if you have these results, what can you do with them to impact prescribing? Another resource that is particularly important in this area is the Pharmacogenomics Knowledge Base, or PharmGKB. PharmGKB is a resource that collects, curates, and disseminates knowledge about the impact of human genetic variation on drug responses. and they catalog relevant pharmacogenetic variants and gene-drug disease relationships based on currently published literature. And what they do is they actually take the FDA drug label, which can be very difficult to find, very difficult to read, and they curate FDA drug labels that contain pharmacogenomic information so that they're easily readable for a clinician or even for a researcher that's trying to quickly access, does this medication have information from the FDA? It sounds simple. It's actually, their website is amazingly user-friendly. It is like you go in and at the very top, there's a search bar and it's like Google, and you just put in the name of a medication, whether that's the brand name or the generic name, and we'll pull up and you can see, oh, there's a guideline on this medication, or there's FDA drug label information, or there's information, there's another pharmacogenomics group in Europe called the Dutch Pharmacogenomics Working Group, and it will tell you, oh, look, the Dutch has information about this. So this is kind of a key resource that anyone who doesn't know something about pharmacogenomics, even a patient, can go look and see whether there is an interaction. I just want to provide one example of how genetics can impact medication prescribing. So at the University of Colorado, we have been enrolling patients since 2015 in a large research study called the Colorado Biobank, where patients provide a blood or saliva sample, and that sample undergoes genetic testing for free. And then we return clinically actionable, meaning something that can impact prescribing, genetic information back to that patient. And there's other genetic information that we also return. I'm just going to focus on the pharmacogenomic piece right now. And so this is all done for free. So this information goes back to a patient. And so in the fall of 22, we had a patient who had enrolled in the biobank, received genetic information, and they had been undergoing chemotherapy and had had significant side effects from their chemotherapy. They had mouth sores, diarrhea, a low white blood cell count, which puts them at risk for infection. And when they received these results, their doctor was able to say, oh, look, this patient is actually a poor metabolizer for this gene that impacts the metabolism of this drug. And so they were able to stop that medication, which at the time felt like the only option. And they didn't even know, are the side effects from this medication or are they from something else? They were able to make that connection and change this patient to a different chemotherapeutic agent, and their side effects resolved. And I love the quote from the doctor that was involved in this case. And he said, I think this can be incredibly helpful in terms of knowing who might have a severe reaction to chemotherapy. And that helps me as a doctor in knowing where it might be dangerous to give a particular chemotherapy. So I love this because I hope it highlights how pharmacogenomics can impact patients. Before we move on and talk about direct-to-consumer genetic testing, I just want to give you a moment to reflect on what we just talked about pharmacogenomics. So we're going to pose another question. So how did this information change your thoughts on pharmacogenomics testing? So I'm going to give you a moment to kind of type in your responses and just kind of think about what we talked about.
So that link is there in chat. And we have some answers coming in.
I'm just going to start reading some of these. It'll scroll back and forth. You can see, I think a lot of you are very familiar with genetics and pharmacogenetics. And so there, it looks like a lot of people are kind of confirming their knowledge. And I love this one. PGX saved my life. I was able to be diagnosed with a mutation in both copies of my genes that encode for COMT. I am now independently functioning, working, and on the right medication. So important. And I saw earlier that a lot of people feel like this is an area of great need for education, and confirmed your knowledge. So that's great. All right, I think we will move on, and we'll move to talk about direct-to-consumer genetic testing. I really appreciate you taking the time to look at that with me. So we are going to move on and talk about direct-to-consumer genetic testing. Obviously, we could spend much more time on pharmacogenomic testing. This is sort of a broad overview of 2 applications of precision medicine. So direct-to-consumer genetic testing, some of you may be very familiar with, some of you may be less familiar with. I will ask you a question about that in just a few minutes. But I will start off and say that this area, whether we like it or not, is an area of growth in genetic testing. The first companies were founded in Silicon Valley in 2005 and 2006. You can see here, this is a diagram of expected growth over the next 7 years. And it's an industry that has experienced tremendous growth since it was first founded. And the direct-to-consumer genetic testing could only be used for health-related purposes starting in 2017. It initially started off as for ancestry purposes. And the move toward health-related purposes has started to have a big impact on care. So we're going to look more in depth on how that's impacting care and how it may impact care in the future. This is just a quick snapshot of some of the major companies involved in direct-to-consumer genetic testing. When I created these slides last month, there were more than 250 companies that offer direct-to-consumer genetic testing. By far, the 2 biggest are 23andMe and Ancestry. They've been around a long time, and the ones that probably get talked about the most in the market. I do want to point out that Ancestry does not provide any health-related information to patients. They did for a short period of time and stopped that service, so we're not going to focus as much on them. Whereas 23andMe is the largest direct-to-consumer genetic testing company providing health-related information to patients. Color Health is a newer company that has made significant gains and been in the headlines more often because it's associated with the All of Us research program. Many of you are likely familiar that the All of Us research program is a large, basically a biobanking program nationally that is trying to get to 1 million participants to be able to lead to direct advances using genetics with patients' health records. And so the color is associated with them, and that's why they're so high up on that list. And then there's a bunch of others listed here. It's important to note that a lot of these companies provide provider order testing. So as a clinician, if you order testing, and direct-to-consumer genetic testing. In terms of reasons for testing, there's a lot of reasons that people will pursue this testing. By far, the most common is ancestry, meaning that you want to know where your genetics might be from. And so that's where a direct-to-consumer genetic testing company would provide you information to say, oh, it looks like based on your genetics that you're of descent from these regions of the world. The kind of the next biggest areas are carrier screening. Just for making sure we're all on the same page, I know many of you are very familiar with what carrier screening is, which refers to the process of looking for genetic variants that someone carries that do not produce disease in the person, but they can pass to their children and lead to disease in their children. The next big category is disease prediction. We talked about this earlier with the BRCA1 and BRCA2 genetic variants that can be used for breast cancer prediction. And then there's many companies that only focus on pharmacogenomics. So a patient can go and get their own pharmacogenomic testing if they want. And then there's this big category of non-medical infotainment. I'm not going to spend a lot of time on it today, but I think it's really important to acknowledge that this is where patients will go, and the direct-to-consumer testing company will advertise these tests that give a patient information about intellectual or psychological predispositions, athletic abilities, dynamics of the aging process, propensity to obesity, specific diets that are indicated by their genetics. And most of these genetic associations don't actually have any scientific merit or anything in the literature to back them up. And so patients may pursue direct-to-consumer genetic testing for non-medical infotainment and actually get real health results, or they may just get these results and then bring to their doctor and say, oh, look, this says that I have this issue related to the aging process, but then there's no scientific evidence to back that up. And we're going to talk a little bit more about the science behind some of the things that direct-to-consumer genetic testing companies the science that these companies rely on and how that impacts the ability to utilize these results. So before we dive a little bit deeper into direct-to-consumer genetic testing, I am just going to pose the following question to you. I'd love to know, how has direct-to-consumer genetic testing impacted your life? And so you should see a poll, and there's a lot of different answers, and you can choose more than one. So I will just pause to allow you to answer that.
I'll give another few seconds here as people answer. And I'm going to go ahead and close the poll in 3, 2, 1, and here are those results.
So a third of you have purchased a testing kit, and it looks like for 52% of you, so a large portion, half, a patient brought their results into you, which would make sense because so many of you are genetic counselors. And then a third, direct-to-consumer genetic testing makes my job as an educator more confusing, which I completely agree with as an educator in this area as well. And then 18% said, I think this type of testing is dangerous and I wouldn't purchase it. Whereas, a few people said, I don't know enough about it to have an opinion. So I really appreciate you taking the time to answer that question. I have to say, compared to the average audience that I talk to, a third of you having purchased a kit is much higher than than typically when I talk to like a mainly physician audience or even a completely patient audience. That it may just be reflective of the group here today, and that often people who are involved in genetics have an interest in seeing these things for themselves. I want to start off just by looking at direct-to-consumer genetic testing in the headlines. These are 4 headlines from the past 4 years related to direct-to-consumer genetic testing. The first one, I had Lynch syndrome for 30 hours, was a New York Times headline. It was a story in 2019 that a genetic counselor wrote. She did direct-to-consumer genetic testing, received positive results for a genetic variant associated with Lynch syndrome, which, for those of you who are unfamiliar, Lynch syndrome is a genetic disease associated with increased risk for many cancers, particularly colon cancer. So she received these positive results, which is very significant health-wise. And she describes her severe anxiety when, even though she knew that this could be a false result, she was still so worried about it. And then she did receive that negative confirmatory testing, and as a genetic counselor had significantly more knowledge than almost anyone else in the population, and talks about her experience with that. And I think that story really highlights what can happen with direct-to-consumer genetic testing. The second headline, the online gene test finds a dangerous mutation, it may well be wrong, was from a New York Times 2018 article. The third headline, a genetic test led 7 women in one family to have major surgery, then the odds changed. This was a story of a family of women who underwent surgical removal of their uteruses and ovaries due to the risk of cancer associated with a particular genetic variant. And they later learned, oh, actually, the laboratory classified this as a significant variant, but many other laboratories don't classify this as a significant variant. And it was very likely that their variant had been inappropriately classified. And so that really brings up some of the issues with laboratories, and we'll talk about that in a couple of slides. And then lastly, why you should be careful about 23andMe's health test was a New York Times headline in 2019. And I think for an educated audience like you may already know the why. I just want to point out some of the key nuances of direct-to-consumer genetic testing versus traditional medical testing. With traditional medical testing, you're going to your doctor orders the test, and the healthcare system then regulates that test. And that means that there are many governmental organizations that enforce regulations to make sure that that testing is done in a laboratory that can provide results in a way that is accurate and in a way that those results can be used in the clinical setting. And the person who gets that information back is the healthcare provider, whether that's the physician, genetic counselor, or others that are involved. Whereas on the direct-to-consumer testing side, the patient initiates that testing, and the FDA regulates that product as a consumer product. They regulate it as a medical device. So direct-to-consumer testing is regulated the same way as a prosthesis or an insulin pump or any other device that someone is using to help with their health. It's not regulated anywhere near or in the same way as a traditional medical test. And then when that information comes back, it comes back to the patient, who may have very significant knowledge or may have very little knowledge. And those health reports aren't necessarily tailored to the patient's knowledge, and they may or may not share that with their healthcare team. This leads to some interesting truths about direct-to-consumer genetic testing that you may or may not be aware of. In terms of the accuracy, finding a health risk often does not mean that a patient will develop the associated health problem. And there was a large study in 2018 that showed a 40% false positive rate for direct-to-consumer genetic testing companies, which is quite high. And many patients are not aware of that, or many people who are doing direct-to-consumer genetic testing are not aware of that. In terms of the scope, reassuring results may be false negatives. And we saw that in some of the headlines that I showed you. For example, 23andMe only screens for 3 of the more than 1,000 clinically important BRCA mutations. This is very important for consumers to know, because a person who receives negative results from a direct-to-consumer test may think, oh, well, my mom had breast cancer and my sister had ovarian cancer, but it looks like I'm negative. And maybe they don't tell their provider that family history because they don't think it's important. Or they feel reassured by this negative test, when in actuality, they didn't get all the appropriate testing that would have occurred if they had gone to a provider to get that testing. And then lastly, what is considered significant can change. And for an educated audience like you, you're very familiar with the fact that variant classification can change. But what's important here to consider is that direct-to-consumer genetic testing laboratories are not held to the same standards as those who do traditional medical testing. And therefore, they can classify something as increased risk that may actually be classified as benign by many other traditional medical laboratories. And that's where you get into these issues of, well, someone receives a result, they think it's increased risk, but is that in actuality true when another laboratory say the same thing? I'm going to highlight what 23andMe tells customers simply because this is, I found in the clinical setting, the most common test that people bring in. And simply just because they're, they have so much marketing. And I would say that I have no ties to 23andMe. In terms of what they tell patients, this is a snapshot of their report from last year for celiac disease. And they do acknowledge, they said, this test does not diagnose celiac disease or any other health condition. They say it does not test for all possible variants, genes, or haplotypes associated with celiac disease. Those are pretty complex terms. A patient may understand the term genes. They may or may not understand variants, particularly haplotypes. Many physicians don't even know what haplotypes are. And then important caveat is that the variants included in this test are common in many ethnicities, but are best studied in people of European descent. And I'm not going to get into all the issues with genetic testing related to ancestry and someone's descent. However, I think this shows that 23andMe is transparent. However, it does, all of the other direct-to-consumer genetic tests are transparent as well. However, someone has to read this. They can't just scroll past this. Many times they'll see positive or negative, and the same thing as a patient looking at an MRI report. They'll look to see the final piece, but they may not see all of the nuance. And that's where your job, if as a healthcare provider or an educator, becomes very complex. In the end, the majority of direct-to-consumer genetic tests are not diagnostic and require confirmatory testing. I used to say all, and that has changed. Some tests are becoming where they are either FDA approved or have they go through a clinical laboratory that has the regulations of traditional medical testing. So I can't say all of them. And that's where I think this becomes even more complicated, is that we can't just say, oh, everything about direct-to-consumer genetic testing is not accurate. However, it requires the provider or the genetic counselor, the healthcare professional to know, I have to go look up if this test can be utilized in clinical decision-making. So in terms of what this means for primary care providers and genetic specialists, we know from a 2019 study of medical professionals' preparation for genomic medicine that only 46% of primary care providers were somewhat prepared or well prepared to discuss these types of tests with their patients. This is in contrast to genetics professionals, where more than 80% feel prepared to have these conversations. And I think that's simply just based on the education that they've received. There was another recent study that showed that 96%, so almost 100%, 96% of primary care providers did not feel confident answering patient questions about this type of testing. And this highlights the need to provide education to not just those that are involved with genetics, but everyone who may come into contact with this. Because as I think someone pointed out earlier in one of the free response questions, there are not enough geneticists and there are not enough genetic counselors, and it's going to take many years to have enough. And so in the meantime, what can we do as the experts in this field to be able to help those who don't have that knowledge? In terms of how to do that, the National Human Genome Research Institute, or NHGRI, has recognized the need for more genomics educational resources. They have a group called ISCC-PEG, that's an acronym, but basically the group has been created it's a group of volunteer health experts that includes genetic counselors, geneticists, non-genetics healthcare professionals who've all come together and volunteer their time to develop resources for healthcare professionals looking to improve their knowledge and skills in genomics. And these are all online. As they build out more and more resources, we'll put in the chat the link to these resources. And this is just a little snippet of their resources for direct-to-consumer genetic testing, you can see that they have an FAQ, or a frequently asked questions for healthcare professionals, as well as they have pharmacogenomic resources. And you can see that their first ones that they list are CPIC that we discussed and PharmGKB. And then they also list the Pharmacogenomics Global Research Network. They have many other resources. These are just snippets of kind of what we talked about today. In terms of patient resources, NHGRI has also recognized the need for patient educational resources. So we will also put this link in the chat. On their webpage, they have fact sheets about genomics. They have a glossary of genetics terms, which is great for when a patient receives a genetics report, they don't know what it means. They can go in and type in a word like haplotype or genetic variant, and it will bring in and tell them what that means. There's infographics and genomics teaching tools. And these are written at the literacy level of an average patient, which typically we're aiming for like 5th to 8th grade or less when we're talking about patient educational resources. I want to bring it all together and say that clearly there's a lot here. This is not a straightforward process, and it's something that will grow and change throughout your career and throughout my career, and is something that requires not just clinicians and healthcare professionals understanding this, but also patients and families. Without precision engagement, we can't have precision medicine. They have to integrate together. And what I mean by that is that we not only need to educate our clinicians, but our families need to know the complexities here too, at least the nuance that when they go to their doctor may not have all of those answers. And they may need more support from a genomics and genetics perspective. And that brings us back to the need for more genetic specialists. So
Dr. Kudron, I just want to pipe up to say we just have a few minutes before we'll have everyone return to Zoom 1.
This is the last 2 slides. That's perfect.
Perfect. Thank you.
So how can patients and their families talk to their doctor about precision medicine? So it's important for patients' families to know what's important to their doctor as well. And this applies to really any healthcare professional, particularly in genetics, family history of a specific disease, and then thinking about medications when it comes to pharmacogenomics are often what a healthcare provider is going to be considering with genetics. And then what's important to you if you're a patient or a family advocate is you have your own personal concerns. And I would say that in order to bring these together, it's essential that patients and families recognize that clinicians have limited time, no matter what that clinician's role is. And so having separate time just for these discussions is really important. So just setting up a separate visit to say, hey, I want to talk about direct-to-consumer genetic testing, or I want to talk about if genetic testing is appropriate for me. And then what can clinicians or healthcare professionals do is recognize their knowledge gaps, utilize these resources that I've talked about. And there's other resources that I didn't have the time to mention today. And then for those of you that are the experts, helping to train the next generation of clinicians and professionals to be prepared to do this, as it's something that professionals recognize the potential of, but may just not have the familiarity to be able to utilize. I can't do this without a large team of people, so I just want to acknowledge all of them. Here are all of my references, and then I'm just going to leave this thank you slide up. And we were going to end with an open-ended question, but I don't know if we have time for that.
I'll put that link in chat. So there's a Mentimeter there in chat, and that'll stay open if you all want to share what change you'll make based on what you learned today. So yeah, let's give a little bit of time for that, and then in a minute or so, we'll transition.
Yeah, and I want to thank Dr. Kudron for a great talk, eye-opening for some to reinforcing current behaviors. And we will be joining up for a Q&A with the telegenetics group. So I wondered, I have a couple of questions, but we'll briefly summarize all of this. How's that in a sentence or two when we move over? But is there any thing anybody's thought of connecting this to telegenetics, Elizabeth, that you want to share?
You know, there's a lot of discussion in connecting all of this to telegenetics. I think the biggest challenge is that telegenetics isn't separate from the regulations that telehealth has to deal with. And so particularly when it comes to genetic counselors have different regulations, just like physicians or any other healthcare professionals have different regulations state to state. And telehealth has different regulations state to state. So I think that's the challenges that are facing genetics. But I have heard often as a potential solution, and hopefully something that over the next 5 to 10 years will be very helpful.
Great. It looks like
So if
Bob.
I could chime in, yeah. So I mean, this is something I've been personally involved with and professionally involved in. I think the key with telegenetics and the primary care issue is to develop collaborative care with geneticists and genetic counselors, where the primary care doctor can do the local stuff and a lot of the heavy lifting, but it requires that kind of a collaborative relationship and working model, which we often don't have anywhere. Unfortunately, when it comes up, it works out great. And telegenetics, I think, is the answer to that. Many places, the regulations are such that if there's one in-person visit, and I have a daughter who has a hypermobility syndrome variant who went to the personalized medicine clinic in Pittsburgh, where I'm in New York State. Once she had an in-person there, they can do the rest telehealth. And so I think that collaborative model will be very useful, because for the primary care doctors to do this without the ability to consult is difficult. For it all to be carried by the genetic counselors and geneticists is impossible because of lack of staff, and also because it's not good care. Good care should be centered in the medical home, and the way to get primary care doctors up to speed is partly education, partly point of care testing. And believe me, I'm a proselytizer on genetics for all of family medicine, and partly learning as you go.
Yeah, Bob, no, this is great. I think Fred is going to tell us we're now overdue on time. I think we
It's
go
true.
into the break a little bit, but this is like, how do we, the time management here? So Fred, tell us what we're supposed to do now.